Hello, everyone. Thank you for coming. Welcome to NAUTO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendees screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAUTO's Executive Director. Norm, the stage is yours.
Thank you, Erica, and thank you everyone for joining us. I know it's been a very busy day. We've had a lot going on, some very powerful sessions and some opportunities to network. I now want to introduce this next plenary session, or concurrent session. You can tell it's been a busy day. Unlocking the Power of Social Determinants of Health, Closing Gaps and Advancing Equity. This session was organized by Dina, Nash, and Fazo from BerryDunn, and our moderator today will be Jill Wilson. So let's go ahead and bring Jill to the stage. McKenna, if you can bring her up with me. Okay, Jill, I'm going to turn the time over to you to moderate and take us through the rest of the session. Thank you.
Great. Thank you, Norm. It's great to be here. Hello, everyone. I'm Jill Wilson from BerryDunn, and I'm excited to be here moderating this session on social determinants of health, how we can close those data gaps and advance health equity across the spectrum. We're going to start with our first presenters, Brenda Watson from Advanta Government Services. She's going to be talking about the social determinants of health diagnoses coding and why it's important to data collection.
Thank you for having me. My name's Brenda Watson. I'm here to talk about why SDOH diagnosis coding standardization is important for data collection. So at this point, right on the first slide, you can see the definition of SDOH. Of note, the letter D is sometimes referred to as determinants and sometimes drivers, as the adoption of drivers in lieu of social determinants. It more accurately describes the ability of policymakers, communities, and individuals to affect the changes that potentially negatively impact the health and well-being of patients. It's important for social determinant codes are important because they help identify and track factors that can impact a patient's health beyond their physical health. And to be more specific, these codes can provide greater specificity about a patient's circumstances, such as their employment, food insecurity, or housing. And the better that we're able to capture and standardize the data capture of these codes, the better information, the better data we're able to have to be able to manage the populations and programs that will ultimately become those interventions that impact people's lives. So why do we want to focus on this? Well, we saw with the pandemic that the healthcare ecosystem demonstrated and became very paramount that social determinants of health with how hospital workflows and how their conditions can impact the value-based care. CMS has added health equity components to the majority of all of their programs. However, we don't have standardized reporting of these codes. And of note, there were studies back looking at how many Z codes in particular that were in the range of social determinants codes have been reported specifically for Medicare beneficiaries, fee-for-service. And in 2018, only 1.3% of the beneficiaries had these codes being reported. And in 2019, only 1.59% of the population of Medicare fee-for-service beneficiaries had the codes being reported. So we have a lot of work to do to be able to beef up our percentage of codes. Again, there's obviously a balance, a seesaw balance, between what's needs to be captured and what's available to be reported. And at this point, I feel very confident that a less than 2% in either of the years, there's a whole lot of room for us to do a better job of reporting of these codes. So looking a little more deeply at the CMS framework for focus, this expanded the capability of CMS to integrate health equity within all of its programs. And so on another slide, in just a few moments, we'll take a look at those pillars or priorities that are the focus of CMS regarding social determinants of health. Of note, which is kind of interesting when you look at this slide on health outcomes, factors, policies, and programs, you can see to the right of that, only 20% of the individual's health is tied to clinical care, includes access to and quality healthcare initiatives, which have been a focus for us for a number of years. And when you look at that, then 80% of the individual's health is really tied to their physical environment. Those social drivers where we live, breathe, work, and play have an 80% focus on our health outcomes. And so now we're trying to take a look at those areas and try to see how we can impact and affect those. And the best way to do that, of course, is to have standardization on reporting of these codes that contribute to these socioeconomic factors. So when we look at the chart, 40% are specifically attributed to socioeconomic factors, 10 physical environment, and 30 health behaviors. So out of those codes that are being reported, you can see that the list of the top 5 are listed on the screen. Of course, not surprisingly, that the number 1 listed code that is currently being reported is the homeless code. Again, thanks to the Gravity Project, we have seen better creation and more accuracy and expansion in the social determinant codes, specifically first with the homelessness, which as of last year became a CC or complication code for reporting on inpatient or part of the IPPS system. And therefore, I would imagine as we begin to look further in retrospect at the volume of social determinant codes that are being captured, we'll see an increase in this specific code. But in general, we want the whole area or the whole scope of social determinant codes to be better utilized and captured. And what are some ways that we can move forward with that? And that includes looking at why is it important? And so on this slide, we're looking at chronic diseases, mental health, and substance use. And this is populated by the HRQ, did a study on this, and you can see that there's a direct correlation with homeless people having chronic diseases. Knowing that somebody's homeless, we can interject programs into someone's life to be able to help limit their need to seek healthcare or maintain their medications, things like that, that will help the overall well-being and healthcare of a patient. So why am I focusing specifically on not just saying we can look at other data and make correlations? Well, the ICD-10-CM diagnosis code for social drivers and social determinants is part of the HIPAA standardized code set that is regulated as the required diagnosis coding system for reporting anything within our healthcare reimbursement and ecosystem. So it's a standard and classification that is already widely accepted, nationally required, and therefore not anything new that people need to address. Who else is looking at social determinants of health? So this slide addresses those specific 5 priorities, and you can see that there were 2 SDOH drivers implemented by CMS. Continuing on, you can see here on this slide that the HEDIS submissions will begin regarding social determinants in May. Data collection started this past 2024. You can also see it in being included with assessments that are being done by providers as part of the MIPS program. And then there are also revenue cycle impacts with different grants and reimbursement structures to be able to better classify and capture these types of services. So now we're looking at not just diagnosis codes, but some of these procedures and being able to capture the assessments that are being done by these providers. So this is just a sample out of Anthem Blue Cross Blue Shield. You can see there are questions. You can look at how the patient responds. And then the far right column are the diagnoses that mirror those. So again, I see a lot of opportunity for us to use AI and integration of data to be able to streamline and make data capture of the social determinants transparent and somewhat easy for us to be able to be better compliant with these data captures. Moving on, we have, I mentioned procedure codes are being developed. So the next couple slides are in the CPT book, and you can see at the bottom of this slide, these are community health integration. I'm not going to go through all the details on the slide, but it's there for your information, and the national average of reimbursement for these codes. So again, you're seeing a push from both the diagnosis and the procedure side. This is a continuation of that same previous slide on the G code there and the rates associated with that and some of the documentation criteria. In addition, there's also what's being added as a G code, a procedure code for social determinants of health risk assessment being done and what those criteria are. So again, we're getting further into our coding, both from a diagnosis and a procedure level. In addition, we have principal illness navigation here, which is another concept that was introduced this past year with another 3 codes and the reimbursements associated with those. Finally, here we have social determinants, why it's important, because it provides deeper impact into our health, in our employment challenges, housing, food, etc. These are just a couple demonstrations of some guidelines on how you can better capture your social determinants of health. And then finally, to wrap up here, going through, we need to collect, we need the data, we need to map the data, analyze the data, and then impact with our programs into people's lives. And policy changes are needed, and you can see the additions of those policy changes here. And then finally, just a summary. What we talked about, identifying those patients, reporting those patients, can then improve quality of care, coordination of care, and even patient experiences with care. Thank you.
Hi, Brenda. Thank you for that great presentation. I'm going to kick things off with the first question for you, if you don't mind. When you talked about the increase in use of the homelessness code, I was thinking that was really interesting. I'm wondering if there are other currently underutilized codes that you have a soft spot for and you'd like to see used more. What would they be and why?
So thanks for the question, and thank you for having me here. First, to answer your question, I was thinking about an example. And I'm going to go with kind of the financial insecurity kind of coding area, because I think that area has a significant impact on patients' ability to be compliant or follow through with potentially treatment plans that maybe they're not comfortable sharing with the providers. And if we can close that gap, I think that there might be other interventions that could be implemented to prevent non-compliance with medications and other therapies. And so let me give you just an example. Somebody that's a diabetic patient who gets discharged, who, is on their insulin, but doesn't qualify for Medicaid, and they're on a fixed income, right? Fixed budget. And they're really worried. We hear this all throughout the news and discussion in Congress, political, right, on cost of these medications. If there's the ability to have that dialogue up front with our clinicians and be able to capture that information through these codes, then there's the potential for us to be able to reach out into those community resources and eliminate non-compliance or potentially even readmissions into other, whether it's an inpatient or a subsequent emergency visit, which, as we know, the more that we keep that hamster wheel churning, whether it's ED or inpatient, there goes our costs for healthcare continue to escalate. So hopefully I answered your question in a long-winded answer.
No, it wasn't long-winded at all. It's really intriguing, actually. I'm not sure that's where I would have gone, so I like your answer. I have another question from the audience, if you don't mind. Oh, look, it's right on the screen. This is fantastic. So there is, you mentioned in 2018 and 2019, less than 2% of the Medicare claims had social determinants of health information on them. Is there any improvement post-COVID? And is there a target percentage that we're trying to hit? Some way that we know when we've gotten to, I'm going to say, sufficient data enough to feel like we've got something to work with?
So I don't know that we're able to make a statement, and I certainly haven't seen anything nationally on what that sweet spot is that you're asking about. But I do feel that 2% or less is definitely not there, at least with millions of people in our population. And I just used a very generic example on medication and a code that could be applied to quite a number of encounters or patients, right? And so I did do a little bit research since we, pulled our information together for today. And unfortunately, believe it or not, 2020 and 2023 still remain at 1.6%. So to me, no movement on that needle, but I think we're getting there, right? I feel like we have a lot of energy behind doing a better job of data capture. So what do I mean by that? I mean that the environment, as I mentioned, expanded with the codes and the diagnosis sections have expanded. It's now last year for FY24. So again, we're not looking at 2023 data, but 2024 is the first time that we're seeing a code become, because of resource consumption, a complication within IPPS. So again, it makes it a code that is probably going to get more volume associated with it. And so I feel like give it another year or two, but what we don't want to do is wait for that. And so on top of that, I guess I would say that I feel like we're on the precipice of sort of new terrain kind of thing, right? So if you remember back, I don't know, maybe the late 70s kind of thing, where we talked about, at least from those of us, anybody on the call that's, plays in the coding arena like I do a lot, can remember that we had accidents and injury codes, and we follow guidelines. And there was no real requirement that certain external cause of accident and injury codes were required. However, we made it required through our guidelines. And that's where we're going, I think, with the social determinant codes. One of the cool things, though, maybe you think it's cool, is that as a byproduct of those guidelines changing on the accident and injuries and claim form being updated through policy and being able to collect this data and analyze this data, we all know we're required by law to wear a seatbelt. Well, that information is a byproduct of those codes being required, because it then became available to see all these horrible accidents and injury coding being reported, and then that external cause of how did these conditions happen. And so I find it that we're kind of in a similar mode to that in the present day with social determinants on how we're going to impact and be successful with interventions and really changing the face of healthcare.
Brenda, thank you. And I really like that seatbelt example. It brings this to life for me. I really appreciate it. We do have a couple more questions. Do you mind if I ask the next one? Does Z59.0 mean that the person has a history of homelessness affecting the current encounter, or must they actually be homeless at the time of the encounter? Do you have any insight into that?
So there are some guidelines, and so it would not be history. So like if you are and homeless, there are coding, as with everything, definitions and guidelines, right? So I won't belabor you with all of my boring computer coding guru here. But for example, again, somebody that resides in a hotel, right, is still considered homeless. So that would be a qualification and be reported on a current encounter. So I think one of the things that's not fully defined out is, when we have a problem or a problem list within our healthcare EMRs, like how frequently should these assessments be updated? And I think I've seen some, that are updating every 6 months because situations and things change. But so it would be on this encounter. It's not a history of homelessness. That's not what that code represents. So did I answer your question again?
You did. Thank you, Brenda. We're going to move on to the next presentation. There will be time again at the end for more questions for you on this important topic. Next up, we're going to hear from Mike O'Neill, the CEO of MedicaSoft, and Erica Galvez, the CEO of Manifest MedEx. They're going to be talking through multidisciplinary approaches to addressing health equity challenges. Here we go.
Welcome. So in a nation of...
In order to talk about
Welcome. So
in order to talk about addressing some of the challenges with health.
Welcome. So in a nation of ever-evolving patchwork laws regarding reproductive access and transgender affirming care, Vermont passed a SHIELD law bill protecting the privacy of not only Vermonters, but also those from out of state who travel for these procedures.
In order to talk about addressing some of the challenges with health equity, Eric and I thought it'd be good first to start with just a high-level definition of health equity, which is offering everyone, despite social, economic background, demographic factors, and so on, to allow them the opportunity to achieve their best health outcomes. And obviously, when we talk about health equity, there are policy perspectives, there's societal factors involved, and so forth. Not to underplay any of those, but what we wanted to focus on for the next 20 minutes or so is what can we in the healthcare industry, especially as a data-driven group, what can we do to influence health equity? And as it turns out, CMS provides a set of goals overall that can direct activities in this area in order to close gaps in access to care and improve the quality of outcomes. One of the fundamental things to do is expand the data that we work with so that we can accurately represent the full patient population. And we also want to set ourselves up to be able to promote screening, to involve social aspects of healthcare outcomes, and so on. In looking at those goals, there are a number of themes that I think we would take away as data-centric folks. One is we're going to need to aggregate data across the full variation in patient populations in order to do things like identifying gaps in care and some of the things that CMS mentions as goals. In order to model and to measure across that population, there are factors that need to be represented in the data for race, ethnicity, sexual orientation, and so on, so that we can get metrics that accurately measure health equity. And we're going to probably need to make data available to communities who maybe ordinarily aren't used to dealing with the complexities of the underlying data and the analytics. And that leads us to some of the architecture or technology implications that we'll talk about as we wrap up our presentation here today. But we can keep in mind things like having a flexibility to handle different data content as our content evolves, to be able to link together different data sets, new data sets, and make sure we're dealing with the same patient, to be able to incorporate sensitive data and address issues of patient consent for sharing, and then to provide the technical tools that allow data specialists and non-data specialists to benefit from the information that we work with here. So I'll turn it over here to Erica to talk about the programs that Manifest MedEx has going. Erica.
Hey, thanks, Mike. And your voice is so soothing. What a nice entrance. So happy to be here. I'm Erica Galvez, CEO of Manifest MedEx, the largest nonprofit health data network serving the state of California. We are focused on delivering health information to a wide range of stakeholders in the interest of improving care, enhancing health, and lowering costs. I won't go through all of the qualifications that we have today, but I do think in the context of health equity, it's helpful to recognize, building on what you described, Mike, the importance of integrating information from multiple data sources across those stakeholders. So on the next slide, I'll give you just a quick sense of what some of the data services look like for Manifest MedEx. And those spread across across several different verticals. We bring in claims information, we bring in clinical information, laboratory results, immunization information, again, from a wide range of stakeholders, and we match that at a person level and then surface that in different ways. In a couple of our product lines, we do that through a portal. So you can see a longitudinal health record that gives you a sense of deep history on an individual, all the way to ADT notifications, and then data feeds or data services that come out of our system and support other platforms. On the next slide, I think we've got some examples of how engaging in this type of service and platform really advance health equity. MX Notify is our ADT notification service. That service delivers notifications for things like care coordination, and we are increasingly providing that information to non-traditional providers. For example, organizations that support communities in need around medically tailored meals or transportation services, or some of those social drivers of health that we know impact health outcomes. We've launched the California ADT network largely because we believe very strongly in the need for a health data safety net that does address some of those systemic or systems level inequities. And in some cases, those amount to simply lack of connectivity across the ecosystem. And so this is a no-cost pathway for ADT sharing across the state of California. I mentioned MX Access, our longitudinal record. We now incorporate demographics like sexual orientation and gender identity alongside race, ethnicity, preferred language to really inform tailored and appropriate engagement with individuals around their care journey. And then understanding not only at an individual level, but at a population level, what some of those disparities might look like and what some logical interventions to address some of those gaps can look like and be really data-driven. So on the next slide, I think I have one really concrete example that'll move through fairly quickly around COVID vaccination and a partnership that MedEx has had with the health plan of San Joaquin. It's a Medi-Cal managed care plan that serves over 400,000 members. This is in the kind of the Central Valley part of California. They actually cover over 90% of San Joaquin County and over 70% of Stanislaus County, and had a real task ahead of them during the pandemic to make sure that as many of their members as possible were vaccinated. And so they came to us recognizing that we were able to bring together information from their claims, from the HPSJ claims set, vaccination data from the Department of Public Health and the local vaccine registry, along with clinical data to provide information that you see on this slide, everything from primary care provider to the number of high-risk comorbidities that would point to potential severe COVID-19 infection. On the next slide, I think this is my last one, gives you a sense of all of the information that we included in these reports that enabled HPSJ and some of their other partners to do very tailored and targeted outreach to their community to increase COVID vaccination rates. I don't have those percentages in front of me, but they're quite impressive. And we do think they were able to increase those vaccination rates, in particular among vulnerable populations, because they had great information to inform and tailor that outreach. So I'll pause there, Mike, and hand it back to you.
Well, thanks, Erica. What I'd like to do here is dive into some of the architecture considerations that support efforts like Erica described at MX. The first thing that I'd like to do, which is a little bit in the weeds, though, is talk about the data model. If we are able to come up with a data model that's flexible and expansive, we can handle the various types of data that Erica described, whether it's claims data, clinical data, various forms of social data, and be able to handle sensitive data as we incorporate things like behavioral health and reproductive data. HL7 FHIR has a standard that provides a very good data model. We think of FHIR these days more in terms of interoperability, but at its heart, it's a very good data model to provide flexibility for a broad set of data. Making a decision early on to standardize on a flexible data model really goes a long way with simplifying the programs that you build on top of your architecture later. We also want to make sure that we have the flexibility to handle the regulatory environment, whether it's CMS and federal rules or state and local regulations. This includes things like handling sensitive data, when we can share data, when we can't share data, how we incorporate patient consent. that kind of flexibility has architectural implications that are important to consider early on. And then we'll want to make sure that there are standard ways for clinicians to access data as patient records as they deliver care, for public health to be able to do analytics, and for increasingly a number of individuals who may not be data experts, but need the information that gets extracted from the data. In our community at NADO, many of us are familiar with fairly standard claims, all-payer claims database type of system where we bring in claims, we do versioning, we may validate them, and we end up with data in a data warehouse to run analytics. If we expand that to handle the types of data that we've just been speaking about here, we can think of maybe a more robust front end that allows us to ingest a variety of data sources, real time and bulk, a repository that organizes that data as patient records, and then a repository that makes that data available as analytics. I know we're moving through this a little bit quickly here, but if we kind of expand that picture just a little bit, you can see that there are a collection of services that would make the kind of architectural choices that I mentioned a moment ago to do things like standardize on the HL7 FHIR data model, to use that as a repository for longitudinal patient records that patients can access themselves, that providers can access, that case managers, care coordinators, anyone who needs to work with patients and their medical history can use this type of data. But we also move data into a relational structure, a data warehouse that's suitable for bulk processing, for reporting, for computing quality measures, and doing the kind of analytics that support the analysis underpinning, measuring our success in achieving health equity improvements. So that kind of platform approach really provides the architectural underpinning for a lot of the programs we've talked about here. And I do think that it's usually good to say at the end, when we think about architecture, there can be a temptation to try to get it perfect before we begin. And we would definitely recommend that while you want to make decisions that don't lock you into silos or kind of short-term dead ends, you also want to take an iterative approach, get started, make the best decisions that you can today, keep enough flexibility for the future, but get started. Beginning with something solid and incrementally improving it is far better than waiting. And as you do that, giving priority to the real use cases that your particular business faces, and engage with stakeholders who are really looking to get information from your data, that's the best way to guide your path forward.
Hi, everybody. Thank you so much for that presentation, Erica and Mike. It was really great. I'm going to start with a question for Mike. You mentioned a phrase that it immediately conjured a picture in my head, this idea of an architectural silo, even an unintentional one. Do you have an example that you could sort of share with us about an unexpected, unintentional architectural silo and how they overcame it?
Sure. So actually very relevant to our discussion here, we've talked about social determinants of health data. Sometimes it's tempting to say, well, look, it's different than what I'm dealing with today. Let's say you're dealing with claims data or you have other clinical data. Let me just get it stored. Let me put it over here in this other place and I'll come back to it later and integrate it. What often happens is it stays there, for forever. That is what I would call a silo. We've got, you can think of literally a farm silo of the data you've been using every day. You stand up another one, and now you're forever building tools to translate back and forth, to match patients, or to integrate it into your queries. If instead of that, you have enough flexibility in your data architecture that you can put it, in some way with your existing data, you will eliminate a lot of that forever having to work around the fact that it's segregated. That's what we meant by a data silo.
Thank you. That's super helpful. Erica, are you able to hear me? I know that you're in a little bit of a transition state.
I'm in a kind of a weird spot for a conference. I apologize, but I can hear you.
Perfect. So there's a question for you coming from the audience. The case study about the COVID vaccine, how did you address an information lag? That sort of delay between when things happen and when we can actually, touch it and feel it in the data. Was it managed through a cloud-based portal? How did you encourage different sources to submit timely information?
Yeah, this is, there's a lot kind of packed into this question. We always encourage our data sources in an ongoing way to submit data to us in real time. So that's kind of the expectation that we set with everyone. Now, there obviously are data sources that don't submit in real time. For example, our state immunization registry, rather than pushing data to us, we query them and pull in immunization records. And so, and sometimes, as everyone knows, there are lags on claims. The fact that we bring information in from clinical sources, claims data, registries, I think often mitigates the lag that might exist from one source, because we're probably getting that information from another source. You know, if it's there's a lag from the registry, we've gotten an immunization feed from the clinic where the vaccination was delivered. So I think our first mitigation on the delay really is just having a multitude of data sources that we match and pull together.
A wealth of data sounds like a problem we'd all love to have, doesn't it? I am sure that leads to other challenges as well when, you know, records are conflicting and things like that, but we'll save that for another time. If you guys don't mind, we're going to move on to the third presentation and we'll cycle back at the end for some more questions. Okay, next up, we're going to hear from Mika Morton, a data analyst at the Green Mountain Care Board in Vermont. And they're going to talk about the architecture of gender-affirming care and reproductive care in data and reporting.
Welcome. So, in a nation of ever-evolving patchwork laws regarding reproductive access and transgender affirming care, Vermont passed a SHIELD law bill protecting the privacy of not only Vermonters, but also those from out of state who travel for these procedures. How is this landscape changing, and how does it impact data collection and resulting research? The Supreme Court's Dobbs v. Jackson Women's Health Organization decision in 2022 overturned Roe v. Wade, generating profound responses nationwide, shaping abortion rights and sparking broad political, legal, and social repercussions. States have pursued vastly different paths in response. 21 states have enacted or activated strict abortion bans and restrictions, many of which have been waiting as trigger laws since before Dobbs. Conversely, other states have enacted SHIELD laws to protect abortion providers and patients. Around the same time, crops of anti-gender affirming care legislation was also making its way through the different state legislature. Most of these laws have been focused on gender affirming care for minors, but lawmakers in 13 states have proposed restrictions on adult health care this year alone. Additionally, the suggested minimum age for care varies by state. For instance, a bill introduced in Kansas would outlaw gender affirming care for individuals under the age of 21, and legislation in Oklahoma would have originally extended their prohibition until 26, although the state senator who introduced the bill lowered the age to 18 after backlash from LGBTQ advocates. Several states, including Idaho, have intensified restriction. Idaho's law against so-called abortion trafficking criminalizes helping minors obtain abortions without parental consent, even if they travel out of state. This law highlights the legal tensions arising as some of the states attempt to criminalize actions beyond their borders, fueling interstate conflicts on reproductive rights. In Texas, Attorney General Paxton's office has attempted to obtain medical records of transgender children getting care outside of Texas, intensifying concerns about privacy and safety. Vermont's SHIELD laws directly counter these tactics. Vermont's recent SHIELD law reflects state-level responses to federal landscape changes post-Dobbs. They establish protections for healthcare providers who offer reproductive and gender-affirming services, as well as for patients who seek this care in Vermont, even if they reside in states with restrictive laws. These bills prevent state authorities from cooperating with out-of-state investigators or civil actions related to these services, reinforcing Vermont's commitment to protecting personal autonomy in healthcare decisions. So let's zoom in a bit on Vermont's first reproductive health services. So as part of Vermont's Health Resource Allocation Plan, we are tasked with assessing the current state of Vermont's reproductive services, which of course, abortion is only a portion of. So how does the SHIELD law impact state data on abortion? So abortion services in Vermont's all-payer claims database are classified. That means we don't have patient identifiers or any information on individual providers. That includes their organization or other geographically identifying information. We have used vital statistics to provide supplemental information and help us fill in the gaps while still maintaining patient anonymity. Reproductive care services is vast. This is not a comprehensive list, but only a snapshot. So let's peek a little bit at the data and the analysis and see what was found. There's too much to present with reproductive care that covers contraceptives, abortion, preventative screening, prenatal care, mental health services, and more. So I've just selected a few interesting points. These numbers are from Vermont Vital Statistics Report and based on the adequacy of prenatal care utilization index. Early and comprehensive prenatal care is essential for a healthy birth and pregnancy. So 6.7% of Vermonters received inadequate care, which is down from 2020. And the age group with the highest percentage of adequate plus intensive care is the 45 plus. This is based on patient origin and abortions per capita. There were 1,033 abortions in 2022, and we opted to use vital statistics data because, as I mentioned, VCare suppresses information on both patient and provider, and I chose to make this per capita so as to account for the difference in populations and counties. Overall, abortion is trending downward, like it is nationally. While women exams are recommended to occur annually as preventative care, so it can be a good indicator for if reproductive preventative care is being utilized, women living in more urban parts of Vermont were 1.48 times more likely to have received a well woman exam than those living in rural areas, highlighting a need for increased access and utilization in the more rural parts of the state. Additionally, women on Medicare are nearly half as likely to have had an annual preventative exam as those on commercial insurance. Similarly to reproductive care, the GMCB was tasked with determining care patterns and needs for transgender affirming care within the state. Gender affirming care encompasses a range of social, psychological, behavioral, and medical interventions designed to support and affirm an individual's gender identity. Gender affirming care can be both for trans or cisgender people, but for the sake of this presentation, I will be referring only to transgender affirming care. With transgender affirming care, there are more data complications. Firstly, not all forms of gender affirming care can be captured in claims. For example, non-discriminatory practices and having well-educated doctors and nurses on gender affirming approaches can't be captured. Social and legal challenges also can't be captured. While most people think only of the medical aspect of gender affirming care, not all transgender people want to medically transition, and instead their transition is exclusively socially. Some may want to medically transition and cannot or choose not to for some other reason. This is all to say, care needs vary vastly between individuals. Plus, Vermont is a small state, and the trans population is estimated at only being 0.5% of the population, and small numbers under 11 must be suppressed to maintain confidentiality and anonymity. And lastly, there's no marker for transgender in VCARES or any other state-level administrative data sources. That data doesn't exist. Additionally, the prescriptions that transgender people receive for gender-affirming hormone therapies are the same prescriptions cisgender people receive for hormone therapies. Mastectomies and breast augmentation are also widely practiced with cisgender patients as well. So we can't use care patterns alone to identify who is transgender. So the question remains, how do we identify who is transgender in the claims database? Diagnosis codes. However, a one-off appointment to discuss gender dysphoria with a provider doesn't necessarily constitute being transgender. I chose to specifically narrow our scope to individuals with two or more encounters with the diagnostic code related to being transgender. I validated this approach against Williams Institute's estimate of approximately 2,700 transgender individuals in Vermont. That resulted in a roughly 74% representation in the claims data, which is what we would expect for VCARES. Hormone replacement therapies for transgender patients is primarily comprised of two categories: feminizing hormones, masculinizing hormones. There are puberty blockers, but they're not represented here. Estrogen, spironolactone, and progesterone are by far the most common feminizing hormones, but not the only options. Masculinizing GHT is primarily testosterone, and over the last 4 years, there's been a significant increase in GHT prescriptions, roughly double the number of prescriptions in both categories. National studies have found that transgender individuals are more likely to suffer from a mental health diagnosis than their cisgender counterparts. These patients experience drastic disparities in suicidality, depression, and anxiety. Additionally, the U.S. Transgender Survey found that nearly 98% of respondents on GAHT reported increased satisfaction with their lives. Looking only at depression in Vermont, there is a significant relationship between taking a prescription for depression and being on GAHT. Those on GAHT are less likely to be on an antidepressant, highlighting the need for continued access to care. There have been 379 gender-affirming surgery procedures for trans folk performed in the last 4 years that were captured in VCures, with the state known. Of those, 136 performed out of state, or approximately 1 in 3. And roughly 54% of those going out of state are on Medicaid. So there is perhaps a lack of surgeons that perform gender-affirming surgeries that take Medicaid in Vermont. The vast majority of surgeries performed in the last 4 years were mastectomies, also called top surgeries, specifically masculinizing top surgery, and nowhere in Vermont does bottom surgery, and only certain types of breast augmentation are done in state. Some quick key takeaways. There are ways to work with the SHIELD law to protect sensitive data while also getting the needed research completed. For reproductive care, Vermont has higher than national average rates of prenatal care and lower than national average abortion rates, but there is a need for pushing for more annual visits in rural population and those using Medicaid. For transgender affirming care, we need more options for surgical providers that take Medicaid in state, and that proper medical access is critical for mental health. Lastly, I just want to provide links to these projects.
Hi, Mika. Thanks for joining us, and thank you so much for that presentation. There's so much about this that we could talk about, but I'm going to start with one question for you. You mentioned that one of the ways you isolated the transgender claims was looking at a diagnosis more than once for, I think, gender dysmorphia or something to that effect. Were there other methods that you explored or that you've since heard about after this project? I mean, is this something that could be standardized, or is it too hard to standardize at this point?
I I think it might be too hard to standardize. I think there are a lot of different ways. I was reading, there's different algorithms that you can build for identifying transgender patients in claims data, and they're complicated, and there's ways to identify, maybe what direction somebody might be transgender, whether they're assigned female at birth or assigned male at birth. And if you're getting into like the weeds of it, then using a more complicated algorithm might be needed. But when you're looking at kind of just like the higher level big picture, this having at least 2 encounters with a diagnosis code related to like gender dysphoria or being transgender was at least sufficient for our needs here.
I'm getting some more questions through the chat, and I hope you don't mind. We're going to post one here for you. What sources have you relied on to find medical codes for gender-affirming care? And this person is especially interested in how you found a comprehensive list of NDCs, or whether you looked up drug names instead, and why you chose not to show puberty blockers.
So starting with kind of at the bottom, why I chose not to show puberty blockers is actually partially because the numbers in Vermont are just so low that I was worried about, looking at like patient confidentiality and that kind of thing at the state level. And then as far as for comprehensive lists of like NDC, so I looked at both sorry, hold on. Drug names, and also I worked with some of the community organizations like the local Vermont Pride Institute for specific drugs that they knew transgender patients were using.
Thank you. I was going to ask you if there was a way that you had gotten what I think of as the community involved in either helping with this research or reviewing the results with you.
Yeah, so I did engage with the local Vermont Pride Center here and like their outreach programs, and there are some like online pride organizations that have these resources available. I also engaged with individual members of the trans community in what
I'm sorry, just for a brief second there, my screen froze. Are you back?
Yeah.
Okay. We're gonna ask one more question, and then we'll sort of bring all our speakers out for a variety of questions. But another question that came through the chat is, are transgendered surgeries covered by insurance without prior authorization?
I think that does kind of depend on the insurance. I can't speak specifically, but I know that by and large they are covered by insurance. But I do believe that they need some form of prior authorization.
Thank you, Mika. So let's bring out all of our speakers. And we did have some earlier questions, in particular, one for you, Brenda. I hope you don't mind if we go back to it. For the social determinants of health codes, did you notice any patterns in which ones tend to be reported? For example, does it seem as though screening is comprehensive, or do they all touch on income or housing or some other specific need?
So in the diagnosis book, they're not really screening codes, right? So we have another section of screening codes. When we're talking social determinants, we're talking about those in a specific range, which I kind of had on one of the slides on the previous during the presentation. But they're like homelessness, like water, like adequate health water, adequate access to water, financial security. It even goes to like level of, education. So is somebody highest level, high school, or, interrelations with family members, somebody passing away, because that can, spiral somebody into, a depression or things like that. So having the ability, so I don't know if I'm, there's a need. It just is the needs might be different in a variety of different categories.
That makes sense. And I think this person was also curious on the volume of the codes. It's a little hard to know if the volume is low, whether it means that the code just hasn't appeared because it hasn't been asked and coded, or if actually that problem just isn't cropping up very much and it is actually coded correctly. Do you have any thoughts about that?
So I'm going to say that we've, again, digging into my sort of coding background, we've seen an evolution, right? So normally when we code things, or what you see in your claims data, are things that meet certain official coding guideline criteria. One of them being that it's reported by a clinician or a QHP, quality, health provider, right? Where certain conditions, like BMI, can be self-reported and therefore captured, right? And so social determinants went through an evolution in our coding guidelines to change that it can now be captured and reported based on self-reporting. So that impacted, I think, the ability that we're going to start seeing it in some data. Again, one of the other points that I kind of alluded to is on the homelessness. Because of resource consumption, it was therefore determined to impact IPPS and potentially OPPS. Therefore, things that impact, you're going to see your facilities capture more timely, more consistently, more accurately. And so what we want to see is not just those being captured that impact IPPS, OPPS, but within this entire code set, because they have impact, as I mentioned before, in public policy, research, and analysis, like with the seatbelt reference earlier. Does that make sense?
It does, and I still love that seatbelt story. Thank you. Mike, we have a question for you next. As we add new types of social determinant of health data, how do we make sure we match it correctly with other types of patient data?
Yeah, this is a good one. And actually, and Eric and I teamed up on this presentation. In a case like Erica's with Manifest MedEx, they come to the table with a lot of patient matching expertise. In fact, an investment in a master patient index, which is a way to say, I've got one unique identifier for a patient and a way to connect all the other identities to that. So we look at it as two things. One, if you take kind of a platform approach to the data, and I know I went through slides very quickly, but there are some examples of the MedicaSoft platform. We can handle ingesting different types of data and then linking to a single patient ID and keep track of that as data changes. But what we like to rely on is what is the source of truth for those single patient identities. And often, if you're used to dealing with, let's say, an APCD style claims data, you may not have had to make the kind of investment in patient matching infrastructure and MPI. So one of the first things that may sound odd that I often recommend is, well, look for somebody who has done that in your state. And maybe I'll turn this over to Erica in a second. It can actually be a shared service. It takes work more than just acquiring a product to actually curate millions of unique identifiers. So if that can be shared across a large organization or across a state or department of the state, there's great benefit to everyone. But in any case, the main thing is have a platform approach to your data that allows you to connect different types of data to a single identity, and then have a uniform way to decide on what those identities are. Erica, is there anything that you might want to add to this based on your experience?
I don't know. You covered it great, Mike. I think an MPI is hugely important. The other thing I might just note is not all vendors are good at all things. And so it's okay to have multiple technology components from different technology vendors. That's what we do at Manifest MedEx. And I would encourage folks, to the extent that that's feasible for you, that you at least consider it, because it makes your system way more modular and allows you to take advantage of kind of the best products across different functions, including MPIs.
Thank you, Erica. I'm going to ask kind of a broader question of all the presenters right now. When I think about comorbidities and multiple conditions and risk stratifications, I think that could fit within each of your presentations, whether it be how does it relate to the care interventions with social determinants of health? How does it relate to keeping all of the data consistent and interoperable? And then also, how does it relate to gender affirming care? So maybe I'll kick it to you, Mika, to start off, but I'd love to hear about comorbidities and risk stratifications and whether or not that's been part of your framework as you've explored these topics.
Yeah, it has. And the way we look at it, if I speak from a MedicaSoft point of view first, uniquely, is to prepare the data so that, let's say you're doing risk assessments or risk adjustments. In order for you to do the best job at running your algorithms, what we try to do is help you be able to apply all of the data that you can. So over the years, you may have done assessments based on claims data, what gets reported. You may then add to clinical data, because I'd like to know what were actually the lab results, not just that there was an order. Now we've had some really good discussion here about social factors. How do we include that? So we look at it as a technology vendor. It's our job to make sure all of the data that you can pull together, you can leverage in the calculations or the analytics or the care that you're delivering. So it's a fundamental thing for us that goes right to flexibility of the architecture, and how can we make it easier for you to use that data.
Thank you, Mike. What about you, Brenda? Have you thought about the comorbidity of social determinants of health data, as well as the medical information comorbidity with the people that are in your data?
So I would say yes. I think that's an opportunity where we can use our assessments to incorporate both. Risk is a wide word or an umbrella word. So sometimes when we think of risk, we think of those HCC codes that are getting captured. Sometimes we think of it just in general terms of what the overall risk for a specific situation. And so when you were talking, I was kind of thinking of it in two ways. One is through the assessment tools, being able to use integration and technology and AI to potentially gather that information, where the assessments are done, pre-visit or off campus, potentially, as before you interact with the patient, and then you're able to use technology to then mirror to the codes that are social determinant codes that are then just reviewed by humans, so to speak, because CMS wants us to still take a look at everything. We can't trust everything to technology, right? So, so I see that as a tool. And I'd also say that I think this is a good opportunity with the claims databases to be looking at our state regulatory and health agencies that are capturing this information to see what's currently out there that can be analyzed and impact, how we move forward with being able to report on these variables.
Thank you, Brenda. Mike, I would have loved to hear from you about comorbidities with the transgender population that you're also studying, but unfortunately we're at time. I want to thank all the speakers for being here. You've been wonderful and you are so insightful. You've shared your knowledge with all of us and I feel like we're better for it. Have a great day.